So let's study about teratogenic exposure of conceptus. So what are teratogen? Teratogen is an agent which can cause abnormality in form or function of fetus, and it can lead to birth defect, fetal loss, fetal growth restriction, impaired neurological performance. The effect of teratogen depends on the teratogen, what is the teratogen, and the period of pregnancy at which the exposure is occurring. So the three periods of fetal growth are pre-embryonic period, fertilization to 2 weeks. Here the fetus follows all or none law. That is, the teratogenic exposure either will cause fetus loss or the fetus will escape injury with no effect. Then in the second period, embryonic period, 3 weeks to 8 weeks, this is the period where the organogenesis occurs. So teratogenic exposure in this period will have maximum birth defects. So this is called the most teratogenic period. Then there is third is fetal period after the 9 weeks to delivery. Here organogenesis is complete, but the growth of fetus and the neurodevelopment is still occurring in this period. So teratogenic period exposure here will have no birth defects, but will have effect on growth and the neurological development of the fetus. Then teratogens, example of teratogens are mental illness, DM in which hyperglycemia, metal infection like torch, then drugs, radiation exposure, alcohol, and increase basal body temperature. So how to know if what investigation we can do in a female of childbearing age, because we always like for first 2 weeks or 3 weeks, like we know this period starts from 3 weeks, but sometimes the patient is not sure of her pregnancy. So for all childbearing age, this is the recommendation. So before any radiological examination, X-ray or CT, you should ask about the pregnancy. Then for non-emergency examination, they can be done in the first 10 days of the cycle. This is called the rule of 10. Then if examination is required, then pregnancy test should be done to rule out pregnancy. In cases like if the female don't remember that she is pregnant or not, she is not sure about her LMP, or if the patient is unconscious or disoriented and cannot tell about the status of pregnancy, then do the UPT and then advise the examination. So the question is, what if we have patient had an RTA, then the patient was unconscious and we did an X-ray, CXR, but so what should we do? Should we do an MTP for that and the and the examination done 6 weeks? No. The safe limit is up to 5 reds. Below that we don't need to do an MTP. So safe limit of radiation exposure in pregnancy is 5 reds or 5 reds. 1 red is equal to 0.01 gyres. So safe limit is 0.05 gyres. Okay. Then in first 2 weeks, this is just summary. First 2 weeks after fertilization, this is this pre-embryonic period, then this is embryonic period. Okay, no, this is not that. So in first 2 weeks, most commonly lead to fetal death, that is all or none law. Fetal death will occur at more than 10 reds, but still the safe limit is 5 reds. Then up to 16 weeks, microcephaly is the most common. Then IUGR can occur, and cancer can occur. For cancer, the exposure limit is more than 20 reds. After 16, exposure up to 50 reds is safe. Indications are absolutely safe in pregnancy are USG, MRI, dental X-ray if absolutely required. X-ray for diagnostic purpose of any disease can be done if they are absolutely required in any week of the pregnancy. But gadolinium, MRI and CT scans are not in pregnancy. But if they are in absolute requirement, like for head and neck, we can do them and use abdominal and pelvic shield. CT of abdomen and pelvis is always contraindicated. Then drugs. So which drugs are teratogenic? They are divided into 5 categories: A, B, C, D and X categories. Okay. So you should just know these. Category X drugs: ACE inhibitor, hormones, valproate, lithium, acetretin, thalidomide, methotrexate, misoprostol, and statins. So let's see which drug causes what kind of effect. So thalidomides, they cause phocomelia. So you can remember this phocomelia with this. This is proximal limb defect. This is the only one that causes this. So this causes proximal limb defect. Warfarin causes de-Sala syndrome. What is de-Sala syndrome? So it will lead to defect in growth of cartilage, which is known as chondro chondrodysplasia punctata. What we see in this? We see in stippled, that is like this kind of stippling in the epiphysis of femur, humerus and calcaneum. So in question they will show you X-ray of epiphysis with stippling and ask you the disease. Then drugs, these are the drugs associated with limb defect. Now we will see the drugs associated with cardiac defect. In that there is lithium, which will cause epsinylomy. What is epsinylomy? It causes some displacement in tricuspid wall, due to which tricuspid desegregation occur, due to which there is ARV, that is atrialization of right ventricle. So in question they can see you this image of echo where they will mention ARV and ask that drug. The clinical features for the ARV will be and tricuspid regression are sinuses and heart failure. On echo we will see the ARV. Serotonin also causes this cardiac defect. And most teratogenic is paroxetine. So most common system involved is CVS in the SSRIs, and the defect they cause is the ASD. So in all pregnant female receiving SRI, do echo. Then drugs that cause cardiac defects and also cause facial dysmorphology are isotretinoin. Phenytoin causes fetal Huntington syndrome, which has cardiac defects and facial dysmorphology. Fetal Huntington, three things. One is facial defect, second is cardiac defect, as we are studying this, and third is limb defect. This is the main feature of this. There will be hypoplastic phalanges and small nails. Then there's alcohol. Alcohol also causes facial dysmorphology plus cardiac defect. Now study the drugs which cause neuropalsies. And here is misoprostol, which causes Mobius syndrome, 6th and 7th palsy. So and misoprostol should not be used in first and second trimester, but we can use it in third trimester for cervical ripening or induction of labor. Drugs. Now we will see drugs which will reduce renal output. Here is ACE inhibitor, which is trastuzumab. What will cause? It will cause neonatal oliguria or anuria. This will lead to decrease in output, which will cause oligohydramnios, and that will lead to pulmonary hypoplasia and limb reduction defects. Then drugs causing facial morphology are methotrexate, which causes methotrexate amniopterin syndrome, in which you see cloverleaf skull. Other drugs that cause facial deformity are phenytoin, isotretinoin, alcohol, and glucocorticoids rarely cause this. So if we have to use glucocorticoids, use less than 10 weeks of gestation. Now we will see drugs associated with cancer, in which we see diethyl stilbestrol. It is not used nowadays much. Now see alcohol-related birth defects. So how much alcohol a female would have consumed to this occur? More than 6 drinks per week. If she is a regular drinker, that means more than 6 drinks per week for more than 2 weeks. If she is a binge drinker, more than 3 drinks per occasion for more than 2 occasions. And binge drinking is more than. So what is fetal alcohol syndrome? Here there is a diagnostic criteria. Remember this mnemonic: Goa's famous beer bar, and just don't know all the criteria. You don't have to remember all the criteria. Just know what is the extension of the mnemonic. So for Goa there is growth impairment. For famous there is facial dysmorphology, then brain abnormality and behavior abnormalities. All there are deformity as their cardiac, renal, skeletal, eyes, everything. So you should differentiate. You should just know this, how to differentiate between a fetal Huntington syndrome and fetal alcohol syndrome. So they are almost similar presentation. Facial deformity present both, severe abnormality present both, and different other are present. The differential factor is first is history. Here will be history of anti-epileptic medication, because Huntington is anti-epileptic. That is phenytoin, which is of Huntington group. Then here will be alcoholic history. Here there are distal limb defect present. Here nothing like that in alcoholic. So this is a different thing that you should remember this one. Now let's come to the teratogenic infection. We are done with the drugs. Now let's come to the infections. First is the cytomegalovirus. Okay, so history that you will have to remember is that there will be history of close contact with toddlers, For this thing for all infections, primary infection will have maximum vertical transmission, secondary infection will have less chances of vertical transmission. For CMV, most common time of transmission is third trimester. Here manifestation will be, there will be microcephaly and all this, but what you have to remember differentiating, that is sensorineural hearing loss. Then this is the most common congenital infection, and it is the most common infection that will cause sensorineural hearing loss. And for diagnosis for all the viruses that we study below is, we will, all the infections, we will check IgM and IgG levels. If IgM is negative and IgG is positive, that means it is a past infection or the patient was vaccinated. IgM positive negative, that means it is recent infection. And recent infection in pregnant female, recent CMV infection in pregnant is an indication for doing amniocentesis. So that we should know that if the infection has transmitted to the fetus or not. If IgM is positive and IgG is positive, then we have to perform every test. If low avidity, that means the infection is recent. If high avidity, it meant the recent was past. So if the female has recent infection, so to know that if the fetus has got the infection or not, we do this amniocentesis, and then we do PCR and NAT for the amniotic sample, and perform USG for congenital malformation occurred already or not. Then second virus is toxoplasma. For that is Toxoplasma gondii, which is a intracellular obligate protozoan. Here there will be history of contact with catfishes. Most common is the third trimester also here. In manifestation of this, you have to remember hydrocephalus, because there previously you have seen microcephaly, here there is hydrocephalus. Then for treatment, if we're treating for mother, then there is drug of choice for mother infection is paramycin, but paramycin doesn't contain placenta. Then for fetus, we use combination of pyrimethamine and sulfadiazine. And since both of these are the folic acid antagonists, we supplement mother with folic acid. Then treatment regimen is, we have to alternate between paramycin and these for 3 weeks, so that we are treating infection of both fetus and mother. Then teratogenic infection, next is rubella. So rubella is the most teratogenic congenital infection, and in both above, the female was asymptomatic. Here the female can have fever and the typical maculopapular rash of rubella. Here the transmission is maximum in first trimester. The manifestation is congenital rubella syndrome, in which the most thing that the differentiating is the heart disease, that is patent ductus arteriosus mediae and pulmonary stenosis. So all female pregnant should be screened for rubella in first trimester, because it is the most teratogenic infection. So all females should be screened for rubella in first trimester, and if present indication, this is then in the first trimester, it is an indication for MTP. Then what if the neonates with rubella infection? So the neonates that acquire rubella infection will shed virus for a long time and are threat of the injured, so don't put them with other neonates, and because that's how they acquire, that's how the mother acquire. Then how to do screening for rubella? If the IgM is positive, IgE is negative, that means it is recent infection, which is an indication for MTP. If the IgM is negative, IgE is negative, that means the mother is not vaccinated. But we cannot give rubella vaccine in pregnancy, as it is a live vaccine. So there is a chance of infection from the vaccine, but we will advise her to get vaccinated after pregnancy. And the duration after pregnancy, she should not conceive again, is for 1 month. But if mistakenly she conceives after vaccination within 1 month, we don't have to terminate pregnancy. So infection first trimester is indication for MTP, but infection after 1 month of vaccination is not the indication for MTP. So just remember this differentiating table for these 3 viruses. For cytomegalovirus, there will be history of close contact. It is mostly in third trimester. The most different which is sensorineural hearing loss and microcephaly. For toxoplasma, contact with catfishes, third trimester. CP is hydrocephalus, and it is a protozoan parasite. For rubella, there will be contact with toddler but here will be trimester first, there will be PDA, cataract. These are the differentiating feature. Okay, we are done with these. Now let's come to parvovirus B19. So for parvovirus B19, you should know that it replicates within erythroblast and thus causes anemia in the fetus. Here there will be history of contact with school going children, and in children that are infected by parvovirus there is slapped cheek appearance. So you can remember this with school going children. Then this will lead to, due to fetal anemia, what happen, there will be hemodilution. So the urine, the fetus will produce more urine and the mother will have polyhydramnios due to that. Then teratogenic potential, it is most common cause of infectious cause of hydros fetalis. Manifestation will be the hydros fetalis and fetal anemia, you have to remember this, and it does not lead to any birth defects. So for hydros fetalis, it is ultrasound based diagnosis. We cannot make the diagnosis clinically. This is done on USG basis. Most common infection causing this is the parvovirus B19. The chances are maximum in the T2. So when the mother diagnosed with parvovirus, next 10 weeks are important because the fetus will develop the hydrops in this period. So if she has not developed yet but she is parvovirus B19 positive, then we will do target scan every 2 weeks and we will measure the peak systolic velocity PSV of the middle cerebral artery. And if the PS is more than 1.5 mmol units, then that the fetus is having severe anemia and will develop hydros fetalis soon. The next is vascular zoster. This agent is the vascular zoster. There will be history of mother coming in contact with the patient of chickenpox. The mother can have fever and flu-like symptom and the pleomorphic rash, which is typical of the varicella or chickenpox. Then teratogenic period is T2, and congenital vascular syndrome is an indication for MTP. So what is congenital vascular syndrome? It is in T2. It has cicatrial skin lesion and limb contracture. These are the two differentiating, and there are other that you don't have to remember. So to prevent vascular zoster in pregnancy, like if the patient gives history of exposure but she has not developed yet chickenpox, we will give vascular zoster immunoglobulin. But if she developed the chickenpox, we will give acyclovir. So these are the differentiating: CMV in T3, toxoplasma T3. Don't remember this. Rubella T1, parvovirus T2, varicella T2. Then neonatal varicella syndrome. So if mother get varicella during T2, it will lead to congenital varicella syndrome. But if pregnant females get chickenpox in 5 days before delivery or 2 days after delivery, then the maternal antibodies won't have been developed to that in such a short span. So the neonate can either get during delivery, that is before delivery, or after delivery from mother through contact, skin to skin contact. This will cause neonatal varicella syndrome. So neonatal varicella syndrome, the neonate will have pleomorphic rash, which is the typical rash of the chickenpox. So if female infection, if after 5 days and has not, or after 2 days has not developed yet, we will give immunoglobulin so that she did not get chickenpox rash and transmit it to the neonate. So for that we will immunoglobulin. But if she developed the rashes and the newborn also get the rashes, the drug of choice is acyclovir. Let's come to herpes infection. So for herpes infection, the CP is most important. In herpes infection, we call herpes, the disease is herpes genitalis, where we will see multiple painful vesicles on vulva and there will be no rashes on any other parts of the body. Etiology is the herpes simplex virus. There will be bilateral polycyclic erosions. The vesicle will go through different stages and then form into polycyclic erosions, and there will also bilateral enlarged tender inguinal lymphadenopathy because the vesicles are in the vulva region. Then diagnosis is by Jank smear. Treatment is acyclovir. And if the patient if the mother has active genital herpes during labor, that is indication for cesarean, because if the neonate comes through by normal delivery through vagina, the neonate also will get this herpes infection. Okay. Then for What is the mandatory C-section indication? If active genital herpes in mother, or mother is having prodromal symptoms, that is vulval pain and penetration, but there are no visible vesicles yet, but still this is C-section indications. Okay, then neonate. What if the neonate got herpes? Then most common time of transmission is during labor, and that we miss the vulval lesions, and the neonate got the herpes, then neonate will develop skin lesion and eye lesions. Last is Zika virus. So Zika virus is a flavivirus. It is have most affinity for CNS. It is spread by vector. Aedes mosquito. It is the only by spreading by this mate. And its most important thing is the affinity for CNS. So it will develop microcephaly and ventriculomegaly, intracanous ulceration, and all these. So we are done with teratogenic.